Hello, everyone. Good to see you. I'm a little short, Casey, so you could hopefully the camera can see over top of the screen. For those of you over there, you can see the top of my head. So my name is Stuart Grande. I'm coming here from the University of Minnesota in the School of Public Health. My background is in the area of community-based participatory research. I am a medical sociologist by training. And so this content, the conversations we're having and what you heard in the first presentation is very near and dear to my heart, especially figuring out ways in which to engage people in better care delivery. So working with Ian and others here in the room on purposeful shared decision making is a real joy, because for the oh, this fantastic. Thank you so much.
I'm all about inclusion.
It's what equity is all about. Oh, that's fantastic. Now I feel bigger. I feel proper. Yeah, so this work is really exciting from my point of view, from a medical sociology point of view, because it is positively disruptive. It looks at things that have been built, things that have been tested, and it says, are these working? Are these doing the job we want them to do? And if not, how do we rethink these processes? So it's not throwing everything out. It's saying what works, what doesn't work, and might we think differently about some of these approaches? And this is why I get really excited about purposeful shared decision making. So both Ian and I have no financial disclosures, although we do make a living doing some of this work, so don't hold that against us. So this is going to be very difficult for me. I was born and raised in the US, but I consider myself fairly cosmopolitan, and I have a very difficult time standing still and talking. If you see me flail and other things, it's because I'm fighting a lot of nerves all at the same time. When I teach, I like to walk around, so this is going to be relatively challenging for me. But I would like all of you to speak up when I ask these questions, and that this is supposed to be an engaging part of the conversation. Dialogue, if you will, bi-directional even. Who in the room and on around the world has heard of shared decision making? Yay! That's great. And how would any of you, those of you who raised your hands, how would you describe shared decision making? In your own words. Please don't pull out a paper and read the first sentence or second sentence from the introduction. How would you describe shared decision making in your own words? I can repeat what you say. And if anybody online gets fired up, you can write it in the chat. Fabulous.
Just speak up.
Or just speak up.
So Marlene yesterday gave us said that there was no consensus of the definition. So, but I really liked how she brought up the definition of working together to make a decision.
Okay. So if I'm in your name? Monse, thank you very much. So if I'm to understand what you're saying correctly, the idea of shared decision making, as you would describe it, is a clinician of some shape, form, making a decision in partnership with a patient, a person who needs something. Okay, great. Good start. I don't disagree. I might have a different way of looking at it, but we'll address that in a minute. Anyone else? How would you describe shared decision making? Should I open the chat?
Sure.
Fabulous. We have people who are fired up on the chat. So,
Mark, I would say it's a conversation where we're pursuing a goal that hopefully respects the autonomy of the patient.
Okay, so Mark, thank you. Did you say making a decision that respects the autonomy of the patient?
Of eventually coming to a decision.
Okay. The goal of eventually coming to a decision. Fair enough. In the title, decision is in the title, so we'd like to think that a decision should be made, right? Okay, great. Thank you. Victor writes, working together to figure out what to do. to solve a problem. Zoe, you're ahead of the game. Two-way conversation, excellent. Patient and clinicians working together. These are all good. A decision based on patient values and meaning. Oh, interesting. Okay, so we're sorry, I didn't mean to say interesting. Fabulous. A decision that brings together or focuses on values and meaning according to the patient. Did we leave anything out? Yeah, patient education. Would you say that is a primary component of shared decision making? A secondary, like where does that fit in the scope? Is it the component of shared decision making? In your view, this is not, there's no right or wrong answer.
Yes, I think so. Because how can someone make a decision if they don't understand?
Yeah.
I would add to that, I think, say shared informed decision making, and somehow that got dropped, and I know there were reasons, but as a clinician and patient need to be informed. That's imperfectly, and that is necessary but not sufficient. We each bring different information. I don't know their values, and they don't know what a randomized trial showed necessarily. And so it is that we both need to be prepared, informed. It's imperfect, but bringing that together.
The idea of patient education to make sure that they understand what's going on to them. I think that's a really important point of view. A very important perspective. Another important perspective of Mark says is that there is a challenge to make sure that patients or people coming to a clinic understand what the evidence says, because there's probably some good evidence to support a decision or a type of care. However, in light of preference sensitive situations, and so preference sensitive situations where there is outcomes that are very similar 3 to 5 years out, the only way to tell the difference is to really ask the patient which matters most to them. Thinking about breast cancer treatment, is it a lumpectomy or mastectomy? And I haven't looked at the data recently, but that's low-hanging fruit in this context to talk about what matters to a patient and how they physically appear should drive that decision. It shouldn't be something else. Mike on the chat talks about managing problematic situations in which multiple parties engage. And Mike and Zoe are both ahead of the curve on this one, so you guys get a star for the day. And Karen talks about in the patient's context, thinking about how to do this from a patient's point of view. All right, wonderful. Thank you all for that, and please don't stop sharing in the room and on Zoom. Given all of that, I'm not going to tell you I'm not going to give you a definition. I'm just going to let you sit there and marinate on the confusion and the complexity of the situation. We are working towards a new way of thinking about this, and I've alluded to the challenge of what decision means. There's a lot of words being tossed out there right now, but we will give you a little bit more context for that in the morning. So in the afternoon. So let's think then on a scale of 1 to 5, 1 being low, being poor, 5 being great. How important do you think shared decision making is in the context of a patient's treatment? 5. 5. 5. We got 5s all around. Stuck the landing. We would be in the very wrong place. And if you're bold enough to say shared decision making is not what medicine's about. Medicine is about evidence and giving patients what they need based on randomized clinical trials. Good for you. That's excellent. And you went to medical school. Congratulations. I think one of the things that I get really excited about when I was sitting there listening to Ian and JP talk is this difference between or the conversation of biological versus biographical. And in my work in shared decision making, I work in the community to better understand the needs of people who are experiencing difficulty being chronically ill or otherwise. And I love the concept of embracing your challenge, whether it's a loss of limb, whether it's some other framing that says that you are not as abled as everyone else, which is the wrong framing to have, in my view. What is a new kind of framing is empowering your uniqueness as a patient, your challenges as a patient, instead of thinking that you're having to take all these medicines and that's a disability or that's a challenge. Changing the conversation around empowered. I am a this, or I have this, or whatever the case may be, is a new way of framing. And I think listening to conversations around overcoming the biological barriers, because when you come into a clinic, often, especially trained physicians and clinicians, they are going to look to the data, because everything in their body since the time they started an education tells them they need to do that. That I am not going to look at the patient. I need to know what your A1C is. We can't have a conversation until I know whether you're stable or not. And that is a real challenge. And it takes a very bold clinician to say, you know what, it's not just about the numbers, it's about something else. That's a big challenge. And you have administrators who don't believe in it. You have administrators saying, I want the numbers. What's your clinic doing? In the conversation earlier, you also heard about the challenges of making sure improving, I hate that word, demonstrating effectiveness of the intervention. How do you demonstrate effectiveness when you don't have the measure to demonstrate it? When a story of a woman going home and feeling like she's home and feeling like that's where she wants to be, how do you measure that from a 1 to 5? Or a value? How do you give a dollar amount to that, to a clinic, to an administrator? Very, very difficult. So I would say it is absolutely a 5. And it is absolutely about thinking about the biography of the patient. Why do you guys think, in your view, I just went off on a tangent and that I tend to do, why I think it's important? Why do you guys think shared decision making is important? What's the driver there?
For me, it's because I do not assume that I know what's best for the patient. And that is the default or the assumption in clinics is, well, let's go ask the doctor what's best. And I don't want to start by assuming that. What's best? Sometimes there is a clearly best option.
Yeah.
Most of the time, there are multiple ways of doing things.
Indeed. In the previous, I'm going to say her name incorrectly. The woman's name from your example earlier, Maria Louise. In Maria's story, what it meant for her to be comfortable or strong or feeling good isn't aligned with diabetes care. I mean, food, carbs, who doesn't like carbs? What about water? What is the deal with water and endocrinologists? Why do they not like water? What's the deal with water? Patients, I can't tell you how many people I talk to. My work is focused on men of color and type 2 diabetes, not specifically on diabetes, but a lot of them show up and I talk to them, and water and being thirsty is a really big part of their life. And clinicians are telling them you can't, which is a very difficult conversation to have. There's a lot of really great comments online. So I think Karen's point about not wanting to make patients miserable is it's a good goal. That's a good, I think that's exactly right. And as far as I understand, the white coating of clinicians requires the Hippocratic oath of some notoriety. And from a sociological point of view, the socialization of clinicians into this space of, I can't remember the Latin term, but do no harm is a big deal. And you do it together, you say it together, it's a collective action. Yet, the curious thing is the biology drives the decision, not the patient's experience. And many of you are commenting that the importance of shared decision-making is looking past those conditions to the person living in those conditions and making sure that you are doing what you can to address their state of being in a way that's authentic to their experience, which I think is really, really valuable. And so I would urge you, as we think about how you have framed, not how I have framed, although I led you down a path, I apologize, how you are framing shared decision-making and why shared decision-making is valuable to you. I would ask you then to say, what is it about, how do you know that shared decision-making has occurred? What would you see? What would you hear? What would you feel? How do you know it's happened? Thank you, Mike. Yeah.
After a conversation between patient and clinician where a lot of things have been discussed, being options or circumstances of the patient. And in the end, the question of, so what do you think, or what would you like to do? And I think that's one of the ways that I would say, well, this is happening, and the clinician is inviting the patient to make the decision together.
Andrew, I love that. So the clinician is inviting the patient into that. I love that. I'm not going to talk about it. Thank you. I'll get into it, but I get ahead of myself. Anyone else? How would you define? How would you know shared decision-making occurred? What would signal that to you?
Sure, I rarely know for sure. And I know when it doesn't happen. You know, we've had a long discussion and a patient that has bleeding on anticoagulation and or anemia, and we finally decide to have a colonoscopy and go through the consultation request, and a day later I get the notice that they cancel it. They didn't want to have it done. I mean, I know I didn't do it well. I know we didn't achieve something. I know somehow there was some coercion, that they acquiesced to something that I wasn't trying to coerce them. And so I know when it doesn't happen. I'm not sure I ever know when it does.
Proving the negative is okay for me in this instance. I think that's recognizing when it doesn't happen and feeling what that, recognizing that feeling of something isn't right. First, that's fabulous. Second, I think that's hard to do in the moment. Michael alluded to the option scale, which is something I've been involved in quite extensively. And we know when we tape a visit, we can then measure it later. It's much harder at the point of care to do it in an instant, to say, ooh, it's happened. But Sandra, your point is a really good one, that if I'm hearing there's an invitation being made, ooh, that signals something's different about this visit. It's not a data dump. It's not a biological test of whether or not you measure up or not, and we need to intervene to lower or raise or titrate or whatever the case may be. Some other points in the online space, I couldn't agree more. Patients ask a lot of questions. Yeah, when you hear patients ask more questions, and in fact, one of the metrics that we've used, and I'll talk about myself. So one of the metrics I've used is to count the number of questions that we hear being asked. We also count and look at spaces in the conversation. When does the clinician stop talking? And it's amazing how little that happens. It's amazing how little patients talk in a visit. And so for us, when we listen to conversations and we don't hear is the patient in the room? Is this a virtual visit? What's happening here? I also like Anne's point around a patient being able to express an understanding of the options. And we're gonna go into that in a little detail later. I think part of what Anne's premise is suggesting is that a patient at some point should be able to restate what's happening, restate their understanding of the events, the conversation. That's a fair justification. And I also, to Zoe's point, I think Zoe's hitting at the question or the premise of the importance, as Mark alluded to earlier, of values and preferences. And sometimes values and preferences are buried in a narrative, in a biographical narrative. And the truth of the matter is, I think when what we're thinking about when we talk about shared decision making is this idea of saying we can apply a technique or a method to elicit some of this, to positively disrupt the habitual framings, the spiels that are used in a clinic, to say, clinician, how about we rethink how we present to a patient? And from a patient's point of view, wait a minute, I get to ask questions. I have some authority in this. I'm not going to be looked at as a disagreeable patient. What's the term that you guys used when a patient doesn't take their medicine? They are labeled as non-compliant. Get out of here. I don't want to do what you're saying because it hurts, because it makes me sick. Is there another option? It's incredible if a patient advocates for themselves, they're non-compliant. Hopefully shared decision making is the opposite of that. And I think we've gone into some detail, and I've extended this conversation enough to say that shared decision making is more than what we're talking about. It's more than the biological. And hopefully we'll get to this space in a moment. Hopefully, Michael brought up the question. Well, it's a technique to engage a patient in understanding their problem. All right, well, fair enough. So what's the problem? Turns out there's a lot of things going on. Does shared decision making attend to all of these all of the time? Can we apply shared decision making uniformly to each of these problems? Anybody? Thoughts? I'll leave that to you guys. I know my students always say, Stuart, that didn't sound like a question. That sounded like you were telling us. And I am not Socrates. That's not my mission. Michael says, I think there are certain behaviors you can observe, but I think they're also a feeling of being involved. So I don't think it's 100% observable. And that is also the case. And I think there's a challenge in this work to recognize the care pathway, which is the illness course of how people are doing their work. So I would argue, and we argue in this presentation, where Ian's going to go into some really important details later, about this being much more than applying a single model to every single problem. We know that what happens at the point of care is more than a choice, a single choice. And that decision, or a decision, yes, could be made, it might not. And as Ian pointed out earlier with JP, there is a lot going on in these conversations. I think at the end of the day, and we've already sort of said this a little bit already, that it's about advancing the patient's problems, maybe not to a solution, but maybe to something that works best for the patient. So the way we would argue, and the way Ian has put this out, is to ask you guys, is there currently a problem-oriented shared decision-making model? Ian, will you walk us through whether the answer to this question, please?
Absolutely. Yeah, that was great. So the reason purposeful shared decision making came up was, and I'm going to go back a couple of slides if I can. Yeah, is this question: what problem is shared decision making the solution to? And Marlene touched on this yesterday. And so what we have here is a bullet list of somewhat traditional targets that shared decision making has focused on going forward, and with the goal of achieving or improving these sorts of things. But we stepped back for a little bit and said, this is great, this is all good, these are valuable things to achieve, but patients don't have these as problems necessarily. So we have evidence uncertainty. Patients don't turn up at the clinic suffering from evidence uncertainty. They might not turn up with suffering from insufficient patient involvement. And this is my favorite quip, so I'm going to say it again. They typically or commonly don't present suffering from ignorance either. And so setting these as the target for what we're trying to achieve through shared decision making seemed inadequate. And so if people come seek your help because there's something wrong in their life, then if we think about shared decision making, Stuart was saying the goal is really to help attend to that conversation, that problem in conversation. And so purposeful shared decision making developed as a problem-oriented shared decision making. The goal isn't so much necessarily to inform or involve patients, it's actually to work together to address problems. And one of the challenges to this framing, of course, is that people have all sorts of problems and they don't neatly fall in one bucket. And so the implications of this are, as we'll see as we go forward, is that you don't treat every problem the same, nor do you talk with patients about those problems in the same way when you're doing shared decision making. And as we'll lay out a little bit as we go forward, that what that means is that there's not one method of shared decision making. How you do shared decision making is going to change with the problems that the patient is experiencing in their life. So to quickly demonstrate that, I'm going to attempt to get this slide to advance. We're going to visit with Rachel. We're going to look at a few vignettes in her life to get the flavor of the different kinds of conversations that are going on, different types of problems that are being addressed, and think a little bit about how what shared decision making needs to be in each situation. So in the first instance, we see Rachel visiting with her primary care clinician. She's currently dissatisfied with her current birth control, and so the two of them are talking together and looking at the possibility of switching. They talk about the pros and cons of the different options and Rachel's thoughts around these different options. They weigh the pros and cons and eventually settle on a decision. So in the next instance, a few years later, Rachel and her partner decide to start a family. We see her here talking with her obstetrician in the third trimester of pregnancy. And what's on her mind is that she's torn about how she wants to give birth. She comes from a culture where 70% of births are via C-section, but now she lives in the States where there's a very different, the proportions are different. She has a circle of friends who really push towards what they call natural birth or vaginal delivery, and she's torn as to how she wants to give birth, and she's talking with her doctor to help work this through. Well, the conversation here isn't necessarily going to focus so much on the pros and cons of the different ways of giving birth, but helping Rachel find how she feels about these options and come to a position that makes peace of this tension. In the third instance, Rachel is admitted to the hospital with sepsis after giving birth. And as she's admitted, she's very concerned about who's going to look after the newborn baby. She's been breastfeeding up to now. She's been no longer able to when she's admitted to the hospital. Who's going to take care of it? Is her partner up to it? And as Rachel's there, her condition worsens. And so there's conversations around, should her parents fly in at this point of time? What needs to be put in place? And of course, there's all sorts of medical discussions going on with her team when she moves to the ICU and trying to put all these different pieces together. It's really complicated. And things get decided on, put in place. But again, it doesn't really happen exactly through an approach of weighing all the pros and cons, laying them all out neatly. There's a lot of, what if we did this? Could this work? Oh, that's an idea. And so that the people involved are engaged in sort of a problem solving approach to working this through. And then unfortunately in the final situation, Rachel here is unresponsive on life support. And obviously this is an awful situation, but in the midst of it, Rachel's husband and her parents are fighting, arguing about what it is that Rachel would want, how the baby should be cared for going forward, and all these sorts of issues. So in order to figure out what to do, what happens is that clinician spends half an hour talking with the family. And in the course of that, there's a backwards and forward, and it gradually emerges what it is that the right thing is to do for Rachel. This process is really talking together to develop sort of existential insight that will give you the wisdom almost to know what to do in this situation. Again, doesn't hinge on the pros and cons of different types of life support. That model of weighing pros and cons just doesn't fit very well in this sort of situation. So, as I say, these are all instances where patients, families, and clinicians are making decisions together. Because they're doing it together, shared decision making. But they're doing it in very different ways, in very different circumstances, using different methods for different purposes. So, to dive a little bit more deeply into this question, well, what are these different shared decision makings? I presented them in the context of a vignette, but I guess the key argument here is that shared decision making is a method. It's a way of getting things done. Like any method, you apply it to its particular purpose. So you don't use the method of firefighting to teach children. It just doesn't make sense. So why would you use one method of shared decision making in instances where it just doesn't apply? So very quickly to run through these different types of shared decision making, we sort of label them from mode 1 to mode 4. So we're going to go through 4 of them. In the first instance, they were talking to answer this question, well, which of these alternatives that we can lay out in front of us is best? And they're really talking about the effects of these different interventions. So in the instance of perhaps turning towards medications, you'd talk about the positive effects, the side effects, the negative effects, how this option affects you in terms of your preferences. And you try to balance all these different effects in order to come to a decision. The second instance where Rachel was conflicted about how to give birth, it's not really so much about the pros and cons, it's the issue is that I could want or adopt the position that I want to have a vaginal delivery. People are telling me to do that, but there's another position which I've grown up in, which is that C-section is the way to go. And so we're trying to work with the different positions of people. So whether it's a societal position, Rachel's position, a clinician's position, trying to in some ways negotiate those so that we can say, okay, this is the position we're going to adopt together as we move forward. In the third instance, the focus of decision making isn't so much on effects, it's actually about the situation. So the problem is the situation. It's not that we don't know what the effects of these options will be. And the way that you deal with troubling situations where there's a lot of different factors going on is that you treat what you're going to do hypothetically. What if we did this? Would that work? Let's think about that for a moment. Oh no, this introduces all these other issues. Well, could we get around it by doing this? And so this is a much more problem-solving way of figuring out what to do. Finally, this fourth mode of shared decision making doesn't deal with effects or positions. It deals with some sort of existential truth. So how do we get to something that's really true to the community, the patient, of everybody who's going through this sort of existential transition? And the idea here is that if we talk together and grasp this truth, then what to do will be obvious. Reaching that point where it's just you had that clarity that this is the right thing to do in this situation. So very shortly, we're going to break into breakout groups, and we're going to ask you to think about, we're going to do a matching exercise, which is essentially, we're going to give you again 4 vignettes, and we're going to ask you within your groups to think about which of these different types of decision making is going on within those. So I'm going to just go very quickly through it. There's a handout that you have that lays out each of these vignettes a little more in detail, but very quickly, here we have Susan. She's talking with her endocrinologist. Yes.
You may want to tell the virtual participants the handout they're looking for is the SDM scenes handout.
So for the online folks, the handout that you're going to want to use is SDMC, I believe. Great, thanks, Casey. So Susan's talking with her endocrinologist. She has diabetes. The medications that she's been using for the last several years no longer proving effective to manage her blood sugar, and so they're considering a different option. They talk about what they might be, how well they would work, different implications of them, and eventually they decide with some hesitation that it's actually time to move towards insulin. Second instance, Susan here out biking, out cycling with her daughter and grandkids, and her blood sugar's dropped. And she falls off her cycle onto a busy road and awakes dazed, confused, and bloodied from this. And obviously, the family around her is very upset and the like. And so as they move out of the situation, Susan's daughter is adamant that she wants her mother off this stuff, by which she means insulin. And so that pressure is on Susan as she goes into the clinician's office. She doesn't know what to do because she has daughter telling her that she wants off this stuff. She's scared of insulin at this point and very hesitant, but at the other time, she's really worried about what will happen if she doesn't do everything she can to manage her diabetes. In the third case, Susan worked at a gas station a little ways from home, and unfortunately, fairly recently, Rachel lost her license. which means that she can no longer drive to work. She has to take public transport to get there, adds 2 more hours to a day for that commute, means she doesn't have time to prepare food the way that she would like to. So she's eating what we would call a less healthy diet. At the same time, cost of insulin's increased 8-fold, which means she can't afford to take insulin. So she's skipping some doses, trying to make it last longer. Talks with the doctor. The doctor points out, well, there is actually another form of insulin, but turns out that she would have to inject that twice daily, which means she would have to inject at work. There's nowhere clean at work or private where she feels that she could do this. And so the doctor and the patient are trying to figure out what to do in this situation. And finally, much later in life, Rachel has been on dialysis for several years. She was super grateful that that was an option when her kidneys failed. But recently she feels like dialysis is just tearing her apart. She doesn't feel like herself anymore. And so when she and her daughter meet with her doctor, this gradually comes out tearfully, and the doctor says, well, there's the possibility of moving towards a more conservative approach, a more palliative approach. And Susan's sort of hesitant. As they talk, it comes out the reason that she's hesitant is she doesn't want to let her daughter down. And they talk through in that conversation and try to, of course, the daughter just wants what's best for her mother. They sort of develop, maybe this is an option. They don't make a decision there, but they decide that they're going to talk amongst the family and maybe pick up this conversation a little later. So with that quick overview sketched out on your sheet as well, I'm going to work on splitting you into breakout rooms of, I think, around 4. Ask you to look at each of these scenarios and match them with the different types of shared decision making that we sketched before. And I'll put that table back up on the screen so you can draw on it. And we'll spend 5 minutes or so, maybe a little less, in the groups thinking about these different types of making decisions together.
You guys can work whoever's closest to you.
Yeah.
Turn around.
You know more about breakout rooms.
You have to go. So we're doing.
How many people do we have on? 18? Five? Yeah.
Is one
big
Yes,
one.
we can.
is on everybody. Yo no esperemos
Chapters.
I don't know what else to do. It's just gonna, there's nothing.
Yeah. Look at that. Show me where they're going.
First one is discussing.
So
May have been before these.
I just put my hand.
Last week.
So I think that's right.
Yeah,
I wrote it as outcomes, but I was thinking.
I'll ask him, because we'll go there.
How would insulin?
Struggling with her medication, she needs something different. So she needs to weigh in on the different that are available out there for her.
Once you stay, like, just. Like, 'cause I don't have a car.
Or like the pressure from her daughter.
Yeah, and the description it states concerns, interest in sports.
In this case, it would be her daughter. Also interesting that they, at the end, they decide to actually hold. And for example, in my opinion, I would say that maybe that would not be the right choice, you know, because you have to control.
Most might take it, sure.
Also interesting. There's no right, like. Agree.
This is working. Right?
If the clinician like continue prescribing the patient. So. And she cannot afford for the insulin anymore.
Okay, so we're going to come back together out of our groups very quickly. Stuart, how do I shut down the?
We missed the last one. I think it's.
All right, so those rooms are closing down, but I think in the interest of time, I'd like to start the conversation. So if you want to move out of your rooms back to the main space, and I'd love to hear, A, if you recognize these situations as being different in kind, and B, if you can see a type of shared decision making that might be operating within them. So again, within the room or within the chat, let's talk a little bit about what you're seeing. So the first question, and this is a leading question, are these situations all the same? Oh, well done, Victor. Good. Second, does anybody disagree that these are all fundamentally the same sort of decision-making situation? Involves a conversation, people are talking, they decide what to do. It's common in all of them. But is there variation?
As he came up with a, I think, very nice reflection on that sometimes many of those different methods happen in the same conversation. So he was telling about that this, like, all of this happen at the same time. You could be a problem, but also dealing with the laugh that the family has among them and dealing more with existential. At the same time, working with different positions. So, like,
Yeah.
is that's a thing, right? Like that it's not only independent ways of doing shared decision. happen within the same conversation.
So what this group is pointing out is that there may be all these different type ways of making decisions that happen within one visit or one encounter. And perhaps we've a little artificially divided it by focusing things in these vignettes. Any comments from the virtual room? Well, let me go this way. So we're going to vote on what we're calling a mode of shared decision making, which goes from 1 to 4 in this table. Do you think was happening when in the last instance where the daughter and the clinician were talking about how dialysis was tearing Susan apart? Chat, raise hands, raise digits.
Don't do that. Don't make it idiot. There you go.
Thank you.
Oh,
See, I'm a Mac user, not a PC user. 4. So Ruth says 4, Karen says 4, Michael says 4. Good. Nike suggests that maybe there's more than these 4 modes, always a possibility. We have a consensus on 4. So either we have groupthink or everybody has identified something that's common in that situation. What about the instance where Susan's fallen off her bike? What's going on there? More votes. I have people in the room who are raising their fingers, but many of them work in this area and know the answers. Good ones. So we have a lot of 2s turning up. Okay. And so we're running out of choices here. So I would argue that the first instance where they're looking at alternate diabetes medications, they're really weighing the pros and cons of those options. And when the instance with the gas station, they're really trying to problem solve how to put all this together. Very quickly, any comments on what it was like to discern these? Was it hard or easy? Did it only work because we gave you a set of possibilities? Sarah.
I was surprised by the last one because there was no decision that was made. So can we talk about why the 4th instance is an example of decision making when no decision was made at that point?
So the question was, the last case didn't look like there was a decision made.
I look at those as the old movies to be continued.
Yeah. Emma.
Because couldn't you say that the decision was to not make a decision?
Yep. No, absolutely. That they're going to keep talking, and arguably that's a decision. All right. Let me move ahead. As we can. So, why this matters, we think, is because if you talk about these things in the wrong way, bad things can happen. So after Susan's fallen off her bike, she sits down with her doctor again, and the doctor just talks about, well, we've got sulfonylureas and we've got insulin, and these are the pros and cons. And if you don't like insulin, then let's do that. Then that may well not really, in a very caring way, address what Susan and her family are going through. Similarly, if we use the same way of making a decision, around this consideration of conservative approaches and really diving into what matters at a deep existential level. Not likely to be super productive when you're considering which of these medications to use up front. Not necessarily going to dive into who people are at an existential level at making that decision. So in the interest of time, I'm going to skip through these. One thing that we're pointing out and making this work is that each of these ways of shared decision making work with fundamentally different materials. Effects, position, situation, or truth. And clinicians in training are mostly taught about effects, not necessarily talk about how to deal with conflicting positions within people, problem-solving situations, or these issues of working with truth. So that might be one of the big gaps, both in shared decision-making and medical education, is that whether we're spending enough time helping people understand how to work with these different things. So then we're going to move forward. So Mark brought up a very good point, which is maybe that there's more, all of these things are happening at once. And recently our colleagues in the Netherlands did a study looking at 100 diabetes videos, and they found, yes, indeed, that these different modes of making decisions or working through issues frequently do occur multiple times or change within visits. So what this is showing here is, this is the, down the bottom here is the first mode that began the conversation. If and when it changed mode, it changed to this. And if it changed again, it changed to this column and the like. And so you can see there were up to 6 changes of mode or ways of making shared decision making that were occurring within each of the visits. And I think what I'd like to do now is, to keep us on time, is to stop, but invite any questions or comments or thoughts, or if this rings true to you, if it's missing something, love to hear thoughts both inside the room and out. Maggie.
I was just thinking, when we were doing the exercise, how helpful it was to kind of have that omniscient view that is sort of writing about the situation from the outside. And it made me think about the challenges for both the patient and the clinician when you kind of come into the space with limited information and maybe certain set of expectations. And it made me think about what are the ways in which you can initially, clinicians and patients can kind of create a space to share enough information that it might become clear which of the 4 types of decision making purposeful SDM this is, because otherwise I imagine it makes a lot of sense to me that people started with options and our alternatives and then had to morph it into something else as information was shared or something became kind of understanding. And so it's interesting to think about, what if the difference was you ask more open-ended questions. I think it also got to the point about, the clinician always doing the talking instead of like creating that space initially to just have the patient describe what's going on. Apologies, my dog is being loud. Yeah, so anyway, those are some things that occurred to me. I thought it was interesting.
I think that's great, Maggie, and it points to the issue of, well, how do you recognize that you should be talking about positions when you've been talking about effects? And how do you develop that sensitivity? Or how do you create an environment within the conversation that actually allows people to be talking about completely different things that you might be? So how do we help people talk about their situations when you're coming in to the conversation thinking you're going to be talking about A1C and the effects? Zoe asks if we can share a reference to the paper with the attractive graph, and I hope that very soon we can. So it's in preparation for publication, and as soon as it comes out, we'll be promoting it through the care unit social media. So I guess I would like to wrap up with one question to the clinicians in the room is, does this reflect what you're seeing in your practice? Mark says no.
Not often. Let's put it that way. Not often enough.
Not often enough. So what's not reflected?
The support for such an endeavor and the willingness by clinicians to slow down, the preparation of clinicians for this. So I was just thinking of a visual way. I'm thinking of it. Surgeons have an operating room and it's quiet and sterile and everyone is prepared and nobody interrupts. What if we envisioned shared decision-making conversations, not with that rigidity and sterility, but with that appreciation for the delicate, fragile nature of it?
Yes, so recognizing that there's a lot of care that needs to go into setting these things up. So there's the fluidity and the grace and the precision.
Victor's used the term elegance, and I really like that, elegance, and unhurried, of course. Not a lot of support for that.
Mark, that's a compelling point, and I as you're talking, I'm thinking of the term vulnerability and how willing clinicians are for being vulnerable in the space to either share or elicit something, because it's a high risk. If you stick to numbers, if you stick to the digits, if you stick to the sterility, and you just are, the weighing is an easy low bar. The other parts require commitment, require extending yourself into an uncertain space. Uncertainty goes up, vulnerability goes up. There needs to be a lot more support in the space to support a method like this.
Okay, last call for questions or comments, and then we will stop. Okay, so Anne has a great question, which is this issue of getting pushback from patients as to making the decision for them, which has been a perennial issue in shared decision making. So it's an interesting question. What's going on here? So maybe what the patient is asking in this case is, don't try and find my position, what it is that I want and what my stance is. I want to talk about effects. And you're much better equipped to talk about effects than I am. So let's talk about effects and work through and make the decision on that basis. Essentially, that reframes the issue from one of who has the authority or who's involved to what it is that we're talking about and what criteria we're going to use to recognize that we made a good decision. Does that, what do you think about that, Anne?
So, I think part of the issue is some of the patients that I work with have a lower general literacy level, and just, you're the doctor, you should know what's best for me type of attitude. And so I've had difficulty in how to help them understand that, what they think and feel about treatments is important. And then I have other patients who, have other belief systems that sometimes I feel aren't even based in reality. But so there's kind of a mixture there, where, especially around the COVID pandemic and vaccines and that type of thing, where people are listening to all sorts of media that is in an other reality.
So that's a great instance of people saying, I don't believe the effects, this is my position.
Exactly. And they're
Yeah.
just, they're not going to, whatever I say isn't going to change their mind.
Mhm. Yeah, so developing the skills to get through that. I feel for you. I don't know how to do that. So. Great.
Ian,
Yes.
a point of reflection on that turn of phrase that Anne just used in terms of, I don't know if I can change their mind. I was once asked, how often are you successful in changing a patient's mind? And I asked the other way around. How often is the patient successful at changing your mind? Right. And so we talked about shared decision making and a conversation, but deep inside, there continues to be a strong professional to patient direction of flow of information, direction, advice, right answer. And there's an opportunity here to revise that and to think about, how often are we showing up to that conversation ready to see it differently?
Yeah, that's great. And so you'll notice the word is positions, not position. And so there's multiple of them floating around the room, and what the clinician holds is a very important and often dominant one. Great. Okay, well, thank you, everybody.